Hi, I'm Krina Patel. I'm Associate Professor at MD Anderson Cancer Center in Houston, Texas, and I do myeloma research and treat myeloma patients. And I think what's really important for our patients to understand that these new immune therapies we have are really great. But one of the things we're seeing is that the targets that they go after, specifically BCMA or B cell maturation antigen, is not only on the myeloma cell, but it's on other cells like normal plasma cells and B cells that actually make antibodies for us that help us to fight infection. And so when you get these, immune therapies, we really want to make sure you don't get major infections, which we've seen in our clinical trials and when we treat our patients with these therapies, especially long-term treatments. And so really there's one option to potentially give these antibodies back. So IVIG. And so really, it's an infusion that has, pooled antibodies. And what's really great about it is that it can actually help against other infections too. So not only are they antibodies to bacteria, but even viruses. So if people who got pooled antibodies had gotten COVID vaccines or other vaccines, you actually might get immunity to that. When some of these other therapies knock down your gamma globulinemia, as we call it. Your gamma globulins, as we call it. And so for me, my patients mostly get IVIG regularly. If they're on a CAR T, they usually get IVIG right before the CAR T if their IgG level is less than 400 or if they've had a major infection recently. And then I do it every month. Again, if they've had infections recently that were serious, I might go ahead and do it every month for at least 6 months and then sort of taper off and only give it when it's less than 400. Again, CAR T, it's a one and done. So we see everything happen in that first, 3 to 6 months. But then we start seeing some of these things come back to normal. So we don't want to overdo it either. And then for bispecifics, because it's a continuous therapy, we know that these levels are just going to keep going down. So again, if my patient has a level less than 400, or they've had a serious infection, I just keep going with it every month. Versus if someone just has low levels, then maybe I'll give it only if it's less than 400. Again, there's some shortages. You have to make sure insurance will cover it. And it can be, it's like 4-hour time for getting it. So it's not a easy, benign treatment. But again, I think very important to consider as a supportive medicine to really decrease those risks of infections. There's other things we do too, like other antibiotics and, things like Bactrim or medications for PJP prophylaxis, because that is something we've seen in patients getting bispecifics, for instance. In Houston, we have a lot of CMV. People have been exposed to it. 90% of people have been exposed to CMV. So we tend to watch for that. And maybe IVIG can help with that too, if you have antibodies to CMV. So again, each region might have different infections and maybe different ways they do this. But I think, especially for bispecifics, having a continuous way of getting IVIG until we know that you're out of the risk of infection is really, really important.